Welcome to PALS. It's Professor Anyanwu's Anatomy Lecture Series. In this place, our goal is to make anatomy simple. If you're just joining us or you have not subscribed, we would like to please do and be part of this amazing anatomy family. In today's lecture, we'll be discussing the anatomy of the pleura. This lecture is divided into two parts. Part 1, which you're watching now, will focus on the basic anatomical features of the pleura. Part 2 will be on pleural recesses and clinical correlates associated with this structure. So let's go to class. In your career in medical practice, you are sure to meet this clinical scenario where your patient's chest radiograph may present features like this. Here we're seeing the features of the lungs on one side of the thoracic cavity, and on this other side, the lung outline is not complete. So the question is, what has happened to the lower part of the lung on this side? This patient will present with shortness of breath, and this is called dyspnea. And depending on the underlying diseases, there could be mild or stabbing pain in the chest, coughing, fever, etc. Percussion on this side of the lungs will give a very dull note or flat note. There will be decrease or absence of breath sounds in this same area. This condition is called pleural effusion. Is our lecture today on pleural effusion? No. But our lecture today will help us to understand, explain, and appreciate the clinical scenario that we stated above. It will also help us to understand other pathological conditions such as pneumothorax, hemothorax, pyothorax, which is also called empyema. Our first task is to locate where the pleural cavity is and what forms it. So this is a transverse section of the thoracic cavity. This is also another transverse section. And then we would like to look at this from the frontal view. So we'll also show you a coronal section, which is here. Let's go to the first diagram here. This thoracic cavity is a transverse section, and it has been divided into 3 compartments, 2 at the sides and then 1 at the middle. The right and left compartments here are actually serous sacs that will be called the pleural cavity, while the central compartment here is the part that will be called the mediastinum. This illustration of the 2 pleural cavities, this one also, right and left, and then the central mediastinum, will help us to understand the adult view of the pleural cavity. Each lateral compartment is actually occupied by a lung enclosed by the pleural cavity, as you can see in this transverse section. These are the 2 lungs, one on the right, one on the left. And then the outline here is this double-layered serous sac, which we'll eventually call the pleural cavity. This view also illustrates what we just showed here. These are actually the layers that formed the pleural cavity, and then these are the lungs that are enclosed within the cavities, and here is the space of the mediastinum with the heart and then the great vessels and other structures passing through the thoracic cavity. This view we have here is actually a true reflection of the pleural cavity. That is, unlike the single layered view we are having here, compared with the double layered view, one on the inner side and this on the outer side. So this is the adult view of the pleural cavity, which is a narrow space. That's a narrow space we have here with two layers, double layer, surrounding the lung structure that we have here. This other view will also help us appreciate. So this is the pleural cavity, and then these are the lungs that are enclosed by the pleural cavity. So the question is, how did we get from this single layer of sac to double layered structure? I will first give you a very brief account, and if that works with you, then I give you a more detailed account. First, the brief account. The lung actually grew into the pleural cavity and got surrounded by it. Let's see how this worked. So this view we have here is actually the single layered serous sac, which we call the pleural cavity we showed you at the beginning. And then let's assume the face to be the lung that will eventually be covered by this pleural sac. So this is our single layered pleural sac, and here is the lung actually growing into this serous sac. And then here we're seeing the enveloping of the lung by this serous sac. So we're seeing the transition from the single layer here to the double layer here, one on the outside and one on the inside. So eventually we're going to have a view like this, the outer, the inner, and the lung tissue in the middle. With a brief account, I will now give you the full account. Actually, during embryonic life, each lateral compartment of the thoracic cavity is occupied by this closed serous sac that will eventually become our pleural cavity. And we can see one here and the other here. And this is the developing lung. We can see one here and also one here. So as a result of development and growth, the growing lungs will expand into the serous sac from its medial side. So this view will also give us that expansion from the medial side. This process of the growth of the lung tissue into the serous sac is called invagination. This will now convert our single layer here to the double layer we are having here. So the outer layer we are having here will be called the parietal layer, and the inner layer we are having here will be called the visceral layer. Now that the background of this lecture is fully established, we will go further to give more details of some of the structures we have already mentioned. So what is the pleura? As we just mentioned earlier, it's a double-layered serous membrane that covers each lung and also lines the inner wall of the thoracic cage. From the view we have here, we're seeing those two layers. This is the inner layer, and then this is the outer layer. Now the pleura is lined by flattened or squamous epithelium, which is also called the mesothelium. This epithelium will secrete a watery lubricant, which will be serous in nature. It's a serous fluid. We'll look at the parts of the pleura. We've already mentioned we have two layers, the outer layer and the inner layer. Here again is the inner layer, which we said is called the visceral layer, and here is the outer layer, which we said is called the parietal layer. The visceral layer will line the surface of the lung, forming its shiny outer surface. So this is the lung tissue. Now, it will line up very strongly attached to this lung tissue, and then will give you the shiny nature we're seeing here. The parietal layer, that's the outer layer, will actually cover the thoracic wall, and then on the inner side will cover the structures that form the mediastinum. So the parietal and visceral layers are separated from each other by a very slim Mostyn potential space, and the name of that space is called the pleural cavity. Here is the pleural cavity where I'm running my light, and here the green line is the parietal pleura, and the blue line here is the visceral pleura, and then the space is the pleural cavity, and the fluid within it is called the pleural fluid. So the cavity is normally filled with a thin film of serous fluid. What this fluid does is to lubricate the two surfaces and will allow them to move on each other without friction during respiration. The pleural space normally contains about 5 to 10 mL of clear fluid, of pleural fluid. This fluid is normally absorbed into the capillaries of the visceral pleura. Any condition that increases the production of the fluid or impairs the drainage of this fluid will result in abnormal accumulation of pleural fluid. As we can see in this illustration, there is already an abnormal accumulation of the fluid. Here, this layer is the outer layer, the parietal layer, and then here is the inner layer, and then we're seeing this accumulation of fluid within the pleural cavity. Now we look at the part of the pleura called the pleural cuff. The structures that come from the mediastinum enter or leave the lung through a structure called the lung root. Now, the depressed aspect of the lung in the medial aspect of the lung is called the lung hilum. Now, this area is the lung hilum, and these structures called the lung root enter the lung through the lung hilum. Now, the pleura surrounds this lung root the same way the cuff of a jacket surrounds the wrist. Let's look at this other structure. Now, assume the wrist here as the lung root, and then this is the lung hilum. Now we see a reflection of the pleura, visceral pleura, that lines the inner aspect of the lungs as it wraps around these structures that are entering the lungs. So in this way it's happening here. This is actual illustration of what we are seeing here. So the pleural cuff is the part of the pleura that surrounds the root of the lungs as they enter or leave the lungs. Now this cuff will extend downwards and hang as a loose fold as we are seeing here. So this loose fold or extension of the cuff is what we call the pulmonary ligament. Here is the cuff, pleural cuff, and this extension down is the pulmonary ligament. Let's appreciate it one more time. In this illustration, here is the pleural cuff, and then here is the extension of the pleural cuff called the pulmonary ligament. Now, what is the function of this pulmonary ligament? Number one, it provides dead space for expansion of pulmonary vein. Let's also look at this. In this illustration, here is the pulmonary vein, and then there will be need for expansion of this vein during increased venous return, like in exercise. So this will create that potential space for this expansion. Then number two, it allows for the descent of the root of the lungs, that is this structure, following the descent of the diaphragm during inspiration. We'll look at the visceral pleura. As we said, this is the inner layer of the pleura. It completely surrounds the lung, except at the hilum, where it formed the pleural cuff. and along the attachment of the pulmonary ligament. The viscera also extends into the depth of the fissures of the lung. Now, in this illustration, we're seeing this part of the lung. This part of the lung is called the fissures. The visceral pleura not only line the outer surface of the lung, but also runs even deep into the lung fissures. It is firmly attached to the lung surface and cannot be separated from the lung surface. So, the parietal pleura is thicker than the visceral pleura, and it lines the walls of the pulmonary cavity. Based on the regions of the thoracic cavity it is covering, the parietal pleura can be divided into 4 parts. We have the part that is called the costal part. Here is the costal part. And also, here is the costal part. We have another part that is called the diaphragmatic part. We now have the mediastinal part, the part that be relating to the mediastinum. And finally, we have the part that relates with the region of the neck, cervical part. We will start with the costal pleura. The costal pleura lines the inner surface of the thoracic wall, the ribs, the costal cartilages, the back of the sternum, the intercostal spaces, and the sides of the vertebral bodies. It is loosely attached to the inner surface of the thoracic wall, and this is through a thin layer of loose areolar tissue, and the name of this tissue is endothoracic fascia. Endothoracic fascia can be easily separated from the thoracic wall, so it makes it easy to separate the lungs from the thoracic wall during surgery. So we'll look at the diaphragmatic pleura. This pleura covers the superior surface of the diaphragm. Here again is the diaphragmatic pleura, and in this next illustration, here is the diaphragmatic pleura. We'll consider the mediastinal pleura. The mediastinal pleura will cover the corresponding mediastinal area of the thoracic cavity. Now, this is the mediastinum. These are the structures in the mediastinum, and this is the mediastinal pleura, the part of the parietal pleura that will cover its own side of the mediastinum. It is the part of the pleura that forms the pleural curve and also the pulmonary ligament. We can see it here. This is the mediastinal part. Here is the mediastinal part. It is also here that the parietal pleura will reflect inwards and continue inwards as the visceral pleura. So the mediastinal region is the part where the parietal pleura will continue as the visceral pleura. It's also the part that will form the pleural curve. It's also the part that will form the pulmonary ligament. Now, the cervical pleura is the part of the pleura that will extend above the superior thoracic aperture into the neck. Here is the superior thoracic aperture. Now, this part of the lung is called the apex of the lung. So, the cervical pleura is the part of the pleura that is seen above this superior thoracic aperture, covering the apex of the lungs. It is also called the pleural cupula. This part lies about 1 inch, which is about 2.5 cm, above the medial end of the clavicle. Here is the clavicle. Now this part is about 2.5 cm above it, and then also about 2 inches, that is 5 cm above the first rib. That's the first rib, and it's about 5 cm above the first rib, and then 2.5 cm above the medial aspect of the clavicle. Before we leave the pleura, we will look at the difference between the parietal and visceral pleura. So it will serve almost as a summary of some of the things we've mentioned. For parietal pleura, it lines the thoracic wall and metasternum, while the visceral pleura will line the surface of the lungs. The parietal pleura, as we noted, is loosely attached to the thoracic wall via the endothoracic fascia, while the visceral pleura is firmly attached to the surface of the lung. Parietal pleura develops from the somatopleuric mesoderm, while the viscera develops from the supranchnopleuric mesoderm. Innervation of the parietal pleura is by somatic nerves, while that for the viscera is autonomic nerves. Parietal pleura is sensitive to pain, while the visceral pleura is insensitive to pain and only sensitive to stretch. The blood supply and lymphatic drainage is same as that of the thoracic wall for the parietal pleura. For the viscera, it is the same for the lungs. This is where we'll end the first part of this lecture. If you have questions, comments, or suggestions, please drop them in the comment section. The part 2 of this lecture is on pleural recesses and clinical correlates associated with the pleura. If you consider this material helpful, we will encourage you to subscribe, like the video, and share it to your friends, that it will also be helpful too. And together we will build a unique anatomy family where our goal will be to make anatomy simple. So thank you for now and see you in my next video.